life was quite a stressful life, and it was one thing my GP had always warned me, that I was, I can't remember how he described it, something like a time bomb ready to explode. He felt that, you know, provided I looked after myself and provided I kept the stress levels down to a minimum, I'd be okay. But there was always the concern that if something stressful happened, who knows, that might be the thing that tipped it over the top as such. And
well, it's the circumflex here.
Got your occlusion,
yeah,
right there.
He was pretty sick, and you would be pretty sick where essentially your LAD circulation is compromised. And you can see it's a whopper. This is a real big one.
It is a large artery.
Yeah.
So Paul said he was very close to retirement. Did you know that when he had his STEMI?
Yeah.
The first real signs that something was wrong actually happened the day before. I got 3 sort of what I would call sharp pains right in the centre of my chest bone. But literally each time it happened, it was for what I would term maybe, I don't know, 5-10 seconds. But it was like somebody'd punched me. And it sort of winded you, but then it went away. And I honestly thought at the time that it was indigestion or something like that. I got up the following morning, I went and got the paper, my wife went out for a ride on a bike. All of a sudden, that thing that I'd had the day before was starting to come back, but wasn't going away this time. So as soon as my wife got back, she phoned 999. I would say within 10 minutes, one of the paramedics was there, I think, in the car, and then the ambulance arrived very shortly afterwards.
I was working with another paramedic called Sonia. We've arrived at the patient's address. We already had a first responder on scene. A lady answered the door and she just had this kind of look in her eye that something really wasn't quite right. And Paul gave a very good history in terms of his symptoms and how he was feeling. And then we put him on the ambulance and did a 12-lead ECG, and he had some ST depression in the anterior leads, but he didn't have any ST elevation. So we decided to do some posterior views, and then lo and behold, when we printed off that ECG, it did demonstrate some ST elevation in the posterior views, which, although for us it was the first time we'd actually came across that as a crew, we decided to take him up to the local catheter lab.
And that particular case, I mean, this ambulance crew came in and this person kind of gave us this brilliant diagnosis in a way. We were all kind of impressed and sort of muttered to each other, who does she think she is? But
I saw the ECG. It's one of the most amazing examples of an acute isolated posterior STEMI I've ever seen.
Yeah.
So to pick up on that and obtain the posterior chest leads is remarkable, isn't it?
Yeah, I think.
I mean, that would be missed by ER physicians. That would be missed by...
It's missed by people constantly, but...
By cardiologists even.
I agree. But if you've been through a training in a systematic way and you've seen it, you've correlated it with angiograms and, you know, the actual procedure, that particular case was just a particularly impressive example. But that's happening all the time now. So that kind of ECG training has been now extended to London Ambulance Service, and it's his training, and specifically Mark, and that kind of culture of methodical interpretation of ECGs, and systematically training all of the London Ambulance Service. We've been part of that, and we've run live case days for them. But what he's done is then created an enthusiasm for training and learning about ECGs, which perhaps medical staff, they never really had.
How did Jackie learn to read an ECG?
I taught her. Spotting the true posterior STEMI is unique. And that for me was the light bulb that switched on to say, I know I'm right in doing this. Because when you implement something, there's always part of your brain that says, am I sure this is right? And it's only when you see real cases and patients benefiting that you know it's right. Because everything we do, regardless of money, regardless of politics, whatever we do has to be in the patient's interest. Otherwise, there's no point in doing it.
I remember the paramedic, the first responder, Natasha. I remember her arriving, and then I went into Natasha and I said, you know, is everything all right? She very calmly said to me, no, he's having a heart attack.
My limbs were heavy, I couldn't lift my arms up, they felt like ton weights. Sweating profusely, dripping off my nose, actually running off like a waterfall. Pain, not in a, you know, you see on the TV programmes, clutching the chest, none of that. I just felt, like I say, more like an indigestion. But I thought this must be, it was too bad. Wasn't a lot of pain, but as soon as she started strapping me up, I knew what she was checking for.
If there could be a more textbook picture of somebody having a heart attack, it would be Steve. He was very sweaty, very pale, in a lot of pain, discomfort, and the ECG was probably the worst ECG I've ever seen in my life. We'd already given pain relief, and it was simply a case of trying to sort of reassure Steve, reassure Stella as well, because she was almost as much of a patient to us, because, you know, obviously it must have been awful for her. I actually remember telling Steve not to worry, and if I look concerned, he should be concerned. And with that, he went to cardiac arrest.
So Steve had had a cardiac arrest out in the community. London ambulance arrived, they've successfully resuscitated Steve, and then on his ECG he had an inferior Stemi, so as is the policy, London Ambulance Service brought Steve direct to us. While we were assessing him and getting him ready to go to the cath lab for his angioplasty and his angiogram, he arrested again.
And also I felt all the time that they was with me. They'd not been called away to be told that the patient they'd brought in hadn't made it. So they just sat with me. Fortunately, they didn't get another call, which was lucky for me, because obviously they would have had to have gone. But I just remember them sitting there with me the whole time and just staying with me, which was just so, well, it just made me stay calm, or as calm as I could stay.
On average, we attend close to 10,000 cardiac arrests a year, and we attempt resuscitation in approximately 50% of those. So we're doing 4,500 to 5,000 active resuscitations a year, and we've been collecting that data since the 90s. So we have a huge data bank of cardiac arrest information.
Well, as I say, it was a day like any other. I'd done a day's work. I was working in south of the river then, in London, and I'd walked to the main train station at London Bridge, and I was at the platform side, waiting for the usual commuter special to get on with everybody else, you know. And apparently I had a cardiac arrest and collapsed.
Years ago, we assumed every cardiac arrest died. You know, we've got a 31.7% survival. I think Seattle and King County, are running at 40–50% VF survival. So patients do survive.
So in your mind, a patient who's been successfully resuscitated from a VF arrest, should they go straight to the cardiac cath lab?
My answer to that question is an unequivocal yes. You don't know the history when somebody arrives in your cath lab in an emergency situation. Often the history of the arrest emerges hours, days later. So my approach to this type of patient is give them the benefit of the doubt. So if you don't know, you have to assume that they have had good quality CPR. If their rhythm on arrival of the crew is VF, then I see that as an excellent sign. And absolutely give them all the chances. It's just a coronary angiogram. For us, we do them all the time. It's easy. We can take the pictures. We can have the answer within a minute, within a few minutes of arrival.
So just to orientate yourself, London is within the M25 motorway, which is the main motorway that loops the capital. It's roughly 620 square miles. So we have over 30 emergency departments. In addition to that, we have a number of specialist hospitals that provide hyperacute stroke care. We have 4 level 1 major trauma centres, one of which can take a helicopter on the roof. And then we have 8 what we designate as heart attack centres, which is where we take the Stemi and some high-risk ACS patients to.
62.
How many ambulances on the street at any given time?
It varies because we do planning of the peak, so it can be up to 250 plus ambulances. And then we have what we call fast response units, which are the cars, and there can be 100 to 120 of those. And then we have motorbikes, and they're usually confined to densely populated areas. And then we have push bikes in densely populated areas, and then we have one helicopter.
You said earlier that STEMI patients were at increased risk of VFib, especially in the beginning phases.
Yes.
Do extra personnel ride along with the paramedic to the hospital?
No.
So, but if they arrested, then
Pull over, shock, and then carry on. Yeah.
Let's not overcomplicate this process.
Exactly. I think you're absolutely right. Don't overcomplicate it.
Yeah.
Because you overcomplicate it, it fails. You're absolutely right.
Yeah.
Absolutely right. Get them to hospital. I'm part of the medical directorate, so my direct line report is the medical director, Dr. Fiona Moore, and I oversee major clinical strategies that we need to implement or make work with a special emphasis on the acute side, namely cardiac. So my background is cardiac. I have a master's degree in cardiology. We've done a lot of work before 2006. So we've done a number of trials of paramedics recording 12-lead ECGs. We started that in the late 90s. So we'd been working on 12-lead ECGs for some time before we actually switched it on in 2006. Prior to 2006, we were taking STEMIs to 2 hospitals in London, to 2 heart attack centres, as a trial just to see what it was like and to learn from it. When we got close to knowing that this was the right thing to do and we were able to do it, we then obviously sat down and went through a training program of how we were going to train everybody, and we produced our own training package in conjunction with Physio Control on how we were going to train over 2,000 staff.
Can your paramedics do an echo in the field?
No, we have taken 10 paramedics and we have trained them to ultrasound the heart during an ALS scenario. We trained them, then brought them back a month later and tested them. And they had a medical student as the patient, and they were doing resuscitation on a mannequin. And then when it came to the pulse, to do your rhythm analysis and your rhythm check, and if necessary a pulse check, they had to find the heart and decide whether it's moving. We knew it was moving because the medical student was alive. But the important thing was, can you find the heart in that short space of time? And 9 out of 10 done it in less than 10 seconds. The person who went over 10 seconds took 10.5 seconds. If they have a clinical question that they can't answer when they're with a patient, or a clinical scenario where they want some further clinical advice, they go through to our emergency operations centre, and there's a desk in there called the clinical hub, which is staffed by paramedics, experienced paramedics, and also a flight paramedic. So all our clinical content within the control room is on one desk, managing London. So crews can access that desk either by radio or by telephone 24/7.
Well, I first started in 2001, so I've been working now 11 years with the service. I worked for 5 years in the control room, and sort of every year to 14 months I kind of worked my way up each through promotion. So call handling, dispatch, radio, allocating, and then being a supervisor, so what we would class as an area controller, which I was responsible for a larger area of London. I can remember when I was training staff, and I still do a session on it when I close every single course currently, and I tell people about an actual cardiac arrest that I dealt with personally on a phone call. And I could picture the whole scene. I could tell you what kind of flooring they had in this kitchen, I could tell you what was cooking in the kitchen, I could tell you what the son and the daughter was wearing, I could tell you absolutely everything around that scene. And I think if you can't picture the scene and you can't almost step into that call or that situation, then it's very difficult to probably handle that call in the most appropriate way. So I actually have the best job, probably I would say, even than the chief executive. So I get that opportunity to deliver exactly what the chief executives instructs and what the trust wants. We get to teach that, and I get to mentor my staff into being able to deliver in that, to make sure that the staff in the control room do the very best job for the patient.
Okay, that will be with lights and sirens. Do you need them turned off, or is it okay to have them on? Okay, sure, okay.
Sent to St Bart's. It was checked there. They were not happy with the position of the ICD, and they said that there was a bit of a problem with it and that it would need, I think, reciting. But he's due an appointment, but not till February, so he's got quite a long way to wait for that. And we just wanted the best for him, really, because we're like, oh, he's okay, but there is obviously a concern. We do need to take him somewhere, I think. But it's just where the best place is for him, really.
We're taking them to a heart attack centre for an expert clinical assessment. Because some people will have ST elevation on their ECG. It looks like a barn door STEMI, but when they have their angiogram, they have completely normal coronary arteries. So we keep talking about identifying STEMIs, and I think that's fine. But I've always said from day one, and had it agreed with the heart attack centres in London, that we will always get a percentage wrong. That's partly due to non-transmission. So someone could argue we should transmit to reduce the false activations. I disagree, because my philosophy is if a technician or a paramedic believes it to be a STEMI, we need an expert to say it's not. And the easiest way to do that is deliver the patient to the expert who can look at the ECG, but can also do an echocardiogram, can also do other investigations way outside the scope of a technician or a paramedic. And then if the expert says, I don't think this is a STEMI, I think this is LVH restraint, I think this is Wellens, I think this is hypertensive heart disease, that's absolutely great. The patient's got an expert assessment, which he would not get in an emergency department, and a treatment plan is instigated straight away that's tailored to the patient. So I'm happy, and I use that term in appropriate context, I'm happy for staff to get it wrong 10 to 15% of the time, providing they are conveying them to a heart attack centre. What I don't want is to get it wrong and take it to the emergency department. So when we do the teaching, to install confidence, we say, you will get it wrong. We are expecting you to get it wrong, but the criteria to activate remains the same. And the reason I want technicians to do the ECG is I want technicians and I want paramedics to have ownership of care. I don't want it to be done by pressing buttons. Now, don't get me wrong, I think there is a clear role for transmission in some systems, but in London, our average running time to a heart attack centre is 16 minutes.
You see lots of TV programs and you see different things, and when it's actually happening to you, it's obviously a different thing. But the one thing I do remember, when the doors opened and I actually went down, there was actually a doctor near enough at the bottom of the stairs to literally greet me and tell me exactly what was going to happen. I was taken very swiftly up to the suite, and Dr. Hill, who was the cardiologist, he told me, asked me a few questions about what had happened and everything else. He then fairly quickly put in a dye into my heart, again confirmed that one of the arteries at the back of my heart was 100% blocked.
Well, we're all interested now in the concept of therapeutic cooling. Out of hospital, in the cath lab, on ITU. I mean, currently all of our arrested patients will get cooled on the intensive care unit. The little incremental progress I think that we're making is thinking, well, can you bring that cooling process back even sooner? So can you start the cooling process as soon as you meet the arrested patient, so start it out of hospital?
The intention is to cool for 24 hours. It'll take another up to 16 hours to start rewarming and get into a normal temperature. And only at that point can we decide whether we can take off all the sedative drugs. That's going to be probably the first time that the family know if that person is actually going to wake up normally or not. So there's a lot of, I suppose, evidence now to say that the best practice for patients who have had cardiac arrest or their hearts have stopped and they've had to be resuscitated in the community especially, or at home, you know, with their families resuscitating them, that their brains are very susceptible to brain injury following that. So the most important thing is probably to cool the brain down so that the brain doesn't have to work as hard anymore and can actually rest.
So I don't think there's any argument about the value of therapeutic hypothermia. There are still many unanswered questions. For example, how cold to make the patient, how fast, with what, and more importantly, where. In the sense the evidence to support pre-hospital hypothermia is not robust enough yet. We know that hypothermia is essential, but whether it should be done 30 minutes earlier in the back of an ambulance or 45 minutes earlier in someone's house is debatable. So the evidence for pre-hospital hypothermia is not as robust as in-hospital hypothermia. And I think that's what's holding everyone back. Most of our heart attack centres are currently doing therapeutic hypothermia once the patient's on the intensive care unit. So I don't have any major objections and I don't have any major obstacles in my way to therapeutic hypothermia because the patients are getting it already. The debate is, do we bring it forward into the pre-hospital arena to start earlier?
But they did explain that, you know, clearly I could have suffered brain damage because I've been a cardiac arrest. But to the best of my knowledge, I haven't. I'm still functioning well.
I think there's an acceptable margin of error. And if you're 100% right on your diagnosis, then you're missing people.
The decision that the paramedics had made was absolutely the most important thing, and they possibly could have saved my life. Because if they'd take me to Farnborough, they would have had to use different sort of treatments and different other things. But the one thing he did say is that, and luckily at the time the paramedics were still standing in the theatre as such, not far away, and he said, you owe them your life. So I was able to actually say thanks, and actually luckily I've actually met them a few times since, which is great. So it's, you know, I realised that without them, I possibly wouldn't have been here today. So.
What do you think's next in the City of London? I mean, 31%, that's a pretty remarkable survival rate, but we know in cities like Seattle, it can be as high as 50%, maybe even higher. How do you see that going forward? Are we doing the best we can do?
I don't think you should accept that this is good enough. I think if you've got a number like that, which has improved very significantly in a relatively short time, then you shouldn't say, well, we've plateaued now. This is just the upwards trajectory. I think you've got to carry on looking at all modifications and permutations of the system of care that you offer. So you've got to, you know, if there are patients whose circulation needs more support out of hospital, then find a way of doing that. So compression device. One of the slightly odd things that happens is when we get this device working well in a patient who's arrested on the table, they often will wake up with this device still massaging their heart whilst they're in VF. I mean, we're quite sort of proud of it in a way. It's one of those services that works well. There's a clear end result, you know, a patient leaving hospital quickly with no problems with their pumping function of their heart, and that's a good result. And, you know, and the majority of our patients with heart attacks will leave hospital in that way. It's great. It's a very satisfying form of medicine.
The culture in the London Ambulance Service by the vast majority of our staff is to deliver excellence in care. And if you talk to any of our staff, they want to deliver the best patient care they possibly can. And sometimes that's where frustration creeps in, because sometimes they struggle to deliver the care they want to deliver because of various reasons. You know, if you go to a patient who you believe doesn't necessarily require an ambulance, and while that's happening, there's an emergency down the road that you can't attend. You know, to a lot of staff, that's uncomfortable. That's uncomfortable. So our staff, if you talk to any of our staff, they want to deliver the best patient care they can. And for me, that's the driver of an ambulance service. That's the driver of quality.